This is QD Clinic, brought to you by Room Now Live, where you can connect, learn, and interact, maybe better than any other meeting. This case is called The Problem with Pain. So I have a 48-year-old male who is well controlled with his rheumatoid arthritis. It's seronegative, and yet he has pains. At any one visit on a scale of 0 to 10, it's a 4, 5, 6, and he always has pain, even though he has no synovitis and he's taking a biologic and a DMARD. The question is, how does he manage pain? He's certainly entitled to pain, even though his RA is well controlled, because he's had RA. He's had antecedent inflammation that's left him with structural changes, some degenerative changes, maybe some periarticular changes that can contribute to pain, and that will come and go with weather, activity, etc. So pain management is a big part of this person's disease control, because they attribute that pain to their RA when in fact it may not be from their RA. So first off, pain is a symptom that is patient-driven. It's not one that you can adequately assess by any other measure other than a 10 centimeter, 10-point visual analog scale. How much pain do you have? And it's something you can follow time to time. Everybody's different. A little bit of pain to this one is a lot of pain to that one. And again, you just have to manage it as best you can by understanding it and understanding the patient and the context within which they get their pain. The problem with pain management is it's either too much, too little, and seldom just right. Now, overmanagement largely occurs when the patient is treating themselves or when you have multiple people in the mix treating the pain. And overmanagement can get the patient into trouble with toxicities. So the classic example is you're giving a nonsteroidal and the patient's taking an over-the-counter nonsteroidal at the same time. We want to avoid self-management. I remind my patients a little tongue-in-cheek that when a doctor treats himself, they have a fool for a patient. When a patient treats himself, what do you think is the story there? It's not going to nearly be as nice as the fool for a doctor-patient. Fool for a patient-doctor. So you have to instruct them that they need to get smart advice from people who manage pain. If not you, then send them to pain management. I don't send them to pain management generally because most pain management doctors are looking to do procedures and make money. Very few of them want to do chronic pain management in people with chronic pain problems. The bottom line in pain control is knowing where their baseline pain comes from and what you can do about it to manage that, and then to manage when their pain gets worse. First, Ben Franklin said an ounce of prevention is worth a pound of cure. Jack Cush says an ounce of prevention is worth about 25 pounds of less heartache and trouble for both you and the patient. So prevention is easy. Lifestyle modification, weight loss, and better sleep are things that can help to manage pain. But most important, and the problem with this particular man in managing his pain was he was doing what all patients do. They wait until they have pain all the time. They don't take pain medicines regularly. They wait until the pain overcomes them, because until then, I'd rather just deal with it, doc, or I can manage it, doc, or I wait until it's bad enough, doc, and then they go and try to take a little Tylenol, a little Advil, a little something, and it's a little, too late, and they're always in pain, more or less, and usually more. So the goal here is that people who have chronic daily pain, more or less, need to have their pain prevented prophylactically. So my way of controlling baseline pain is to put someone on a long-acting acetaminophen, 650 milligrams, 2 pills twice a day, 3 pills once a day in the morning. If they have no liver disease and have normal LFTs, they can take up to 6 pills a day, no problem. And that's all forms of acetaminophen, assuming they're not on narcotics with acetaminophen in it. But that would be their daily pain control medicine, 3 Tylenol arthritis every morning, or if their pain is mainly at night, every night. And then they need a strategy to rescue pain. And that would be to use PRN, other agents like low-dose over-the-counter Advil, or a prescription nonsteroidal, or intermittent tramadol. If they need more than that and a strong narcotic, they're going to have to go to pain management and hope that that works out for them. Pain management can be difficult, but it really takes a good dialogue between you and your patients to best control the pain. I want to talk to you about the faculty at Room Now Live. It's incredible. We have an incredible faculty. Just our first day, our faculty includes Kevin Winthrop, Roy Fleischman, and John Giles talking about TB, zoster, advanced therapies in RA, and cardiovascular risk. Then we have Bevra Hahn, Nicola Dalbeth, and Dan Wallace talking on the history of rheumatology. And then we have Chris Richland, Alan Mentor, and Jose Scher talking about management of psoriatic disease. It's just an incredible lineup, and that's just the first afternoon. There's 3 other half-day sessions that we're going to do from Friday afternoon till Sunday morning. Go to roomnow.live to register before all the seats are taken.